Thank you everyone for joining us tonight, and welcome to this BMA webinar on outsourcing during the times of the COVID pandemic. I'm delighted to welcome our speakers today, and we've got a really interesting 90 minutes ahead of us. My name's David Wrigley. I'm a GP in Carnforth, which is in North Lancashire, and I'm the Deputy Chair of BMA Council. The BMA is the Doctors' Trade Union. We have over 163,000 members, and we speak for and represent doctors from the very first day as a medical student right through to their retirement. It's been a really challenging year for us all. We're in the midst of a global pandemic. Here in the UK, working in the NHS, we're already exhausted, and now at the start of a second wave that none of us really know what's ahead of us, both as a profession, but also for our patients. From the outset of the pandemic, we knew the NHS was not in a good place. A shortage of tens of thousands of doctors and nurses. We knew that vital NHS funding had been cut back due to austerity economics. We had a woeful lack of hospital beds and the resources we need to care for our patients. Waiting lists were already huge before the pandemic hit us. The BMA has been the leading voice speaking out on many issues during this pandemic. We've undertaken hundreds of interviews with our reps across the UK, and our headlines too numerous. One of the first aspects we saw was the unforgivable, inadequate supply of PPE that we've had for many months. NHS staff were confronting a deadly virus without the right equipment to deal with the vital work we need to do for our patients. On behalf of the BMA, I called for the government to repurpose UK factories and industry to make PPE for frontline workers, industry which in April was inactive due to furlough. The government ignored us, and they handed billions of pounds to companies for contracts to import PPE, contracts that on many occasions didn't deliver. The BMA noticed really early on the worryingly high prevalence of deaths due to COVID amongst our BAME colleagues. Incidentally, it was the BMA that first called this out in an article in The Guardian on the 10th of April by our chair, Dr. Chan Nagpur. The first 10 doctors who died from COVID were BAME colleagues. We called on government for a systematic review of why this was happening, and even now today, the government has stalled this process and not tackled it. We've had to continue with major concerns over the test and trace system in England, and we'll be talking about this tonight amongst many other things. Contracts worth billions of pounds have been handed to the private sector for test and trace with no governance or oversight. The national system in England is not delivering. And we heard the other week that management consultants brought in to deal with this are receiving £6,000 per day per person. Yes, £6,000 a day per person. And we're astonished to hear that 15 people on the Test and Trace Executive Committee, out of 15, there's only one public health expert. The space for former executives from Jaguar Land Rover, a senior manager from Travelex, former bankers, and an executive from Waitrose. Since 2012, when the coalition government pushed through the almost universally unpopular Health and Social Care Act, public health has been eviscerated in England. It was a once well-respected and well-resourced public health service. They used to be embedded in the local communities who knew them well, and they were savagely cut back, often made redundant by the local authorities they were moved into, who themselves didn't have enough funding to deliver services. The devolved nations didn't make that mistake. They now have well-functioning public health services able to effectively track and trace those affected by COVID. There are real lessons to be learned here. The BMA has long campaigned for an NHS that is publicly funded, publicly provided, and publicly accountable. We have nothing like this in England, and tonight's presentations and discussion should make us realise where England and our politicians have gone so badly wrong. And we might be able to turn the clock back and salvage something from the mess that we're in. It also stands as a stark reminder and a warning to our colleagues in the devolved nations not to go down this route. So, before we go to our speakers and their opening remarks, I'd like you to know that you've all been muted. We'll be holding a question and answer session at the end and a discussion. Now, if you signed in on a laptop, there is a question function at the side of your screen. You'll see a question mark inside a speech bubble that's below the hand symbol. If you signed in on a mobile device, a question mark should appear at the bottom of the platform. If you click on that, you can submit questions to our panelists. Please do type and send in some questions, and we'll be receiving them during the evening, and we'll do our best to get them asked and answered in the after the presentations. Our speakers will all each speak for up to 15 minutes, and I'll make sure they keep on time and give them a 1-minute reminder near the end. The webinar is being recorded and it will be available later on the website. So, without further ado, I'd like to introduce our first speaker. Polly Toynbee is The Guardian's well-known political and social commentator. She's a former BBC Social Affairs editor. She's won National Press Awards as Commentator of the Year and the George Orwell Prize. She's authored several books, including Hospital, Lost Children, and Hard Work, Life in a Low-Paid Britain. And just published is The Lost Decade, 2010 to 2020. And that book is a survey of those years, what went wrong, what went right, and what's next for Britain. So thank you very much for joining us, Polly, and over to you.
Thank you very much. Well, ever since the beginning of the NHS, the service had ideological enemies, and Aaron Bevan warned that it was always going to need doughty defenders, and certainly the BMA is one of those. The COVID pandemic has summoned unprecedented emotional public support, the clapping, the rainbows, the praise, the affection. You'd say to yourself, wouldn't you, surely no politician in their right mind would dare to lay a finger on it now. Well, no, not a full frontal assault, but COVID has opened the back door to billions being siphoned off to the private providers without contest or scrutiny, without letting the NHS and local authority public health services prove that they can offer better value for the astronomical sums now being spent in the private sector. Some 12 billion has been spent alone for a failed, centralised, privatised test and trace system, and its results have been going backwards. This month it's only had 67% success in reaching contacts within 24 hours, but in comparison, the Local Government Association reports that their localised contract tracing has had a 97% local success rate. The excellent BMA report that has just been published, COVID-19 and the role of outsourcing, collates what we know, but there are still a great many unknowns. The Guardian has been on the case from the start, so has the FT and the HSJ and quite a few others. I think that one emblematic name that may stand out in future years, it will be PestFix, something nobody had ever heard of before. Here's a company that barely existed, assets of only £18,000, no PPE experience, yet it was awarded a remarkable contract for 32 million to buy PPE, with unusually 75% of that money paid up front against government financial rules. And then it was gifted 5 more contracts worth 313 million. Contracts have not been reported within the statutory 30 days. Why the secrecy? Why was the NHS excluded? Why so many authentic PPE manufacturers not included? In the BMA report, you're going to find plenty of those examples. And many of these companies had very close ties to number 10, such as the £580,000 contract given to Hanbury Strategy, not for health, but for messaging. Hanbury's founder was Director of Communications for the Vote Leave campaign, working very closely with Dominic Cummings. Cabinet Office refused an FOI, Freedom of Information request on that deal. Meanwhile, 840 million has gone to another public opinion firm called, misleadingly, Public First, with close connections to Michael Gove and Dominic Cummings. Now, I don't know what kind of messaging they do for that amount of money, but any serious communications professional would have prevented the greatest messaging disaster of the pandemic, the failure to sack Dominic Cummings instantly as a public warning for breaking COVID rules. That failure helps to explain the alarming finding by the SAGE Behavioural Subcommittee that only 11% of those traced are now fully obeying the 2-week quarantine, as the public is losing trust. And that's the most precious thing to have lost. The colossal sums siphoned off into private contracts without scrutiny will be unknown to most of the NHS-loving public. Private companies disguise themselves as NHS partners using the NHS logo. Test trace system has not been, should not have been branded NHS, but Serco and Cytel. Incidentally, Serco, who are running 500 of the government's test sites and call centres, has just seen its profits soar, and it's about to pay at the end of this year a fat dividend direct from taxpayer to shareholder. The scale of contracting out in the name of the pandemic suggests a real danger that this becomes endemic in future NHS procurement. In the 2012 Health and Social Security Act, Health and Social Care Act, public health was given to local councils with a promise that the money would be ring-fenced, but it wasn't. As we chronicle in our book, The Lost Decade, the local authorities suffered 40% of cuts in their government funding in the decade from 2010, and so public health was plundered. Everything everywhere has been plundered in the austerity decade, leaving the public realm weak and threadbare to face the COVID crisis. Capacity has been stripped out everywhere, not just the doctors and nurses missing from the NHS now with 80,000 unfilled vacancies, but capacity and experience in Whitehall departments, very important, in local government, amongst environmental health officers or health and safety officers, school staffing, and yes, even the army has been shrunken, smaller than it's ever been, which the government, of course, turns to now because of their lack of police. A diminished state was the ideological purpose of austerity. The danger for the NHS is the same old one as always. It's always lurking in the wings. Its enemies always claim the NHS is not sustainable. The more it's underfunded, the more justified NHS enemies feel in promoting private funding alternatives. They reach for the usual, private insurance or top-ups paid by patients in one form or another. The concept of a purely publicly funded NHS offends those ideologues, just as the BBC offends them, that other great national institution paid for by all, for all. The current NHS crisis, with over 50,000 patients waiting over a year for treatment and a quarter of cancer referrals waiting over 2 months, is an opportunity for the privatisers. Those brutal waiting times, incidentally, splashed across right-wing front pages, were researched by a private company called Medifer, which bids for contracts to triage patients between GP and hospital, using consultants, the medical, not the Deloitte kind, for virtual consultations. So, of course, they want to highlight NHS deficiencies. There are plentiful think tanks on the right, constantly undermining the NHS. Reforms, I just picked one at random. Reform's upcoming event is billed to explore fundamental questions about the shape of the state, claiming COVID-19 has, quote, exposed some of the NHS's biggest flaws. The NHS has been crippled for funds since 2010, and despite all those early, remember those big early ads of big face of David Cameron promising, I will cut the debt, not the National Health Service. The NHS has suffered a decade of the lowest growth since 1948, a rising population and a 25% increase in the number of over 65s who use the NHS most. Per capita, it has certainly been cut. The perverse result of those cuts, oddly enough, until this COVID bonanza, the private sector was a bit less keen to bid for NHS contracts than was anticipated by the creators of the 2012 Act. Richard Branson's Virgin and others nibbled around the edges, making profits out of community services, but the private sector shied away from big, underfunded, complex, acute services that they were expected to bid for. Remember, Circle made an extravagant promises to turn around efficiency and value when it took over the struggling Hinchinbrook Hospital. But its fingers were so badly burnt it handed the hospital back within just 6 months, and no more boasting. And that's the trick with private contracts every time. If they're not profitable, just hand them back, as with the railways. There are no penalties for failures in this huge bunch of current COVID-related contracts. Another problem with private contracts is their rigidity. The NHS now needs more than ever to be nimble, flexible, imaginative, but a contract set in cement blocks any agility and change. Just look at what happened with the PFIs. Currently, the NHS is trying to stitch together fragmented services back together again after the 2012 Act into ICS's integrated care systems, replacing the 2012 Act's fruitless competition with a more coherent, area-based unity of community and acute services. But the 2012 Act stands in the way of keeping services within the NHS. Richard Branson has already been to court using the Act to demand services be tendered out competitively as the law demands. But here's the odd thing. Where are Branson and his lawyers right now to challenge all these enormous contracts handed out to Downing Street's friends with no competition or transparency? It seems his challenge was just against a service staying in the NHS. Perhaps these excluded private bidders are just keeping quiet, expecting a share of the spoils, as indeed the private hospitals have had with a high tariff per operation. It's an optimistic assumption that at the end of all this, there will be an almighty day of reckoning. Some hyper inquiry will investigate all that was done well and badly, by whom and why, with mortifying lessons to be learned. But I'm not quite sure why Boris Johnson, Dominic Cummings, Michael Gove would allow that. And if you look how intent they are on diminishing the power of judicial review, who's going to conduct this commission if judges are the enemies of the people? We know the contempt with which Downing Street holds Parliament as well as the law. So I'm not really holding my breath at the moment for some deep dive public inquest. Of course, the admirable National Audit Office and the Public Accounts Committee will count the cost, and they will report on where the money went and how well or badly those billions were spent on private consultants, lobbyists, pest fix providers, and the rest. But sadly, the NAO's politically embarrassing financial reports tend just to be one day's bad news, more prominent in the FT and the Guardian than in the Daily Mail and the Sun. These ministers have learnt to shrug off bad facts with their own alternative facts. But to end on a slight note of optimism, I don't think the old enemies of the NHS will succeed in turning this crisis to their ideological advantage. Their claim that an underfunded service is unsustainable will be greeted by a loud public demand that it be sustained in perpetuity and free for everyone. We need to be vigilant about a government allowing its friends to feed on generous contracts, and it's our job to make sure the public knows where the money is flowing. All who work in the service, all of you, must make sure the public knows the difference between an NHS service and a Serco or a G4S wolf masquerading in NHS costume. Thank you.
Well, thank you, Polly. That was excellent. And you're absolutely right. When we hear people say, oh, the NHS can't cope, let's bring in the private sector, that's because the NHS has been underfunded and cut back so much in recent years, and the ideology behind that allows them to justify bringing in the private sector. So we can explore that later, but thank you very much for that, Polly. I'd like to now move on to our next speaker, David Rowland, who is the Director of the Centre for Health and the Public Interest. And he's a former research fellow in the Health Policy Unit at University College London. He's written on a range of subjects including the Private Finance Initiative, the role of the private sector in the NHS, conflicts of interest in healthcare, and patient safety in private hospitals and social care markets. In 2013, he co-authored a report for the CHPI, which warned that the UK was unprepared for a pandemic, highlighting the reliance on private companies to deliver the response and a lack of system-wide coordination. He writes regularly for BMJ, LSE Policy, The Guardian, The Independent, and The New Statesman, and has degrees in political science and political theory from the LSE. So thank you very much for joining us, David, and over to you.
Can you hear me? Okay.
We can,
Right.
thank you.
Great. Okay. So I'd just like to say thank you very much for the opportunity to speak to you all this evening. As I can't see any of you, I don't actually know how many people I'm talking to, but I hope what I say in the next 10 minutes will be engaging and also hopefully raise a slightly different perspective on the issues raised. And that is because of the fact that my training, unlike a lot of you in the audience tonight, was not in public health, was not in medicine, but was actually as a political scientist. And that's, in a sense, how I have approached lots of these issues relating to changes within health and social care policy. So I thought I'd just take you through an analytical framework, which is something which influenced our thinking in relation to both marketisation and outsourcing within the NHS and social care, but also in relation to the study that we did in 2013 around preparations for a possible pandemic. Okay, so the basic idea that is a feature of much of the understanding of how we think about the state right now is that it's moved from a situation back in the late 1980s, early 1990s, to the idea that the state should not be there as the direct provider of essential key public services. And this idea was encapsulated by a couple of political scientists back in the 1990s as the notion of the hollowed out state. Now, I think we're all quite familiar with the idea of the hollowed out state because it's something which we're experiencing right now, but it has a number of key components to it, which I think are definitely relevant to how we think and understand the predicament that we're currently facing. So the first aspect of that was the notion that it should be public services provided not directly by the state, but by private providers operating under contracts and using markets to deliver some of the key outputs. There was also a heavy focus on efficiency and seeking ways in which we could get lowest cost to the taxpayer for providing those services. There was a very strong focus on the reduction of regulation and bureaucracy and a reduction in the role of the public servant in favour of the private sector manager. So the ideas that we're now contending with have quite a long antecedents. They go back 20, 30 years. So we need to start thinking, in a sense, about not just where we are now, but actually how we got here. So I'm just trying to change the screen. The consequences of this hollowed out state is the notion that the government machinery becomes fragmented. This leaves it in a situation where it's difficult to coordinate and plan the provision of public services. It also has, as a result, a lack of resilience to respond to unforeseen events. And crucially, there is increasingly a lack of accountability for those providing public services. In terms of where power sits within the hollowed out state, what you see is a transfer of power away from the state to private providers. And Polly has talked very much about how that has happened with lots of the contracts that have been struck quite recently. So we applied this framework back in 2013 to try and get an understanding of the extent to which the Lansley reforms, which were contained within the Health and Social Care Act, would actually impact on those very key functions of government which were there and designed to protect the population from infectious disease. So we published a report in 2013, and as you can see from this slide, which is an article more than 6 years old, we talked about the fact that the UK was unprepared for a pandemic. Now, this was despite the fact that a pandemic has been the #1 risk on the civilian risk register, not just in terms of likelihood, but also in terms of severity. The reason why we found that the UK was likely to be in difficulty when a pandemic hit was because of the fact that the NHS had shifted away from what was in the immediate post-war period, and then for a long time afterwards, a command and control based system. And we realized that even though there had been changes which had happened, moving it closer and closer to a more market-based system prior to 2012, what we identified was that the full development of a competitive market-based system could not be relied upon to respond to a national emergency. The structures that had been put in place to create that market created fragmentation, not just within the NHS, but the development also of relationships between the NHS, local government, and crucially, public health. We identified the fact that within a market-based system, there is very little incentive to create anything relating to resilience, and also it prevents, by its nature, any interest in producing surge capacity, the type of surge capacity that we needed suddenly to switch on and create at the very last minute in order to be able to cope in some way with the current pandemic. And finally, the structure that we encountered was one which undermined accountability. So it was very unclear when looking at the overall health system from the perspective of thinking about what happens within a pandemic situation. It was very unclear where accountability lay for both decisions, but also for providing responses. And again, as Polly has pointed out, that is one of the key fundamental problems with the current reliance on a whole host of non-state actors to be able to provide the UK's response to the current crisis. Now, since 2013, since we wrote that report, we were worried back then. Now what we've seen since 2013, again, as Polly has pointed out, is a big reduction in the funding going to the NHS. There's also been a big reduction in capital infrastructure as well. There's been a big reduction in the resources available for public health, and as we have documented in quite a number of our reports, a big increase in the use of the private sector to deliver NHS services. So put together, all of those various trends since 2013 onwards have led to a further hollowing out of the state and a further reliance on private providers operating under the various different forms of contract to provide the pandemic response. Now, one of the things that I think was perhaps not fully appreciated in the various discussions around the reliance of the NHS and public health and the government more widely on the private sector is the extent to which COVID-19 has actually created new opportunities for private providers in the private hospital sector. So at the beginning of the pandemic, a contract was arranged between the private hospital network, the Independent Healthcare Providers Network, and NHS England, which effectively allowed the NHS to use the private hospitals' facilities on the basis that those private hospital companies, would be reimbursed purely on a cost basis. Now, since those arrangements were put in place, there have been numerous anecdotes about the fact that those private hospital facilities have not been used. But what we do know is that hundreds of millions of pounds have been paid to the private hospital sector since March. In the future, there is a plan over the next 4 years to increase the amount of funding that goes into the private hospital sector to treat NHS patients from around £1.5 billion a year to around £2.5 billion a year. Now, in terms of the overall structure of the NHS and its previous reliance on the private sector, that amounts to a significant increase, a 66% increase in the amount of revenues that will be going to the private hospital sector in the future. And in addition, therefore, a 66% increase in the number of NHS patients who were treated in the private hospitals. To date, there are no contracts published relating to either the deals that were struck back in March, nor are there any contracts which have been published relating to the £10 billion deal for the next 4 years. We don't know how taxpayer funds have been used. We don't know how many NHS patients have been treated. But what we do know is that large multinational private healthcare companies are now almost entirely dependent on the NHS for their financial survival. And that's because of the fact that during the COVID crisis at the start, and it's continuing to impact upon their customer base, the private payers who were previously the largest source of revenue for the private hospital sector were unable to attend, and had it not been for the funding that came into the private hospital sector from the NHS, the private hospital sector more generally would have suffered the fate of lots of other companies who have suffered substantially during the COVID pandemic. Now, what is seen when looking at the data that is available on this, the very scant data that is available, is that there are now some private healthcare companies who previously had a very, very low reliance on the NHS to now segmenting themselves as a future part of NHS provision. Now, there are a number of questions which emerge out of that. First of all, where were these decisions taken in relation to these contracts? What is the basis on which taxpayers can expect to get value for money? And finally, a substantial question around the safety arrangements for NHS patients who are treated in private hospitals, because this is something we have documented in quite substantial detail over the years, that the post-operative care arrangements in private hospitals are significantly poorer than exist in NHS hospitals, and the clinical governance arrangements that exist in private hospitals are also less than adequate compared to that which exists within the NHS. So in addition to the transfer of power from public health and local government to track and trace services, there has also been a very substantial transfer of power to multinational private healthcare providers who are as yet to be held to account for any of the public money which has been passed over to them. So I'll just conclude there, but for more information about the work that we do and to look in more detail at some of those issues relating to patient safety in private hospitals, you can check out our website and also follow us on Twitter. Thank you.
Well, thank you, David. That was fascinating about the lack of accountability, but also how the state has been hollowed out by successive government policies. And it was incredible to see that you exposed that lack of preparedness for where we are now 6 years ago. And it just shows that often we see government doesn't listen to experts or professionals, and if they do, it's in a better place. I think one aspect that we know about, that many patients in the NHS, their care was stopped when the pandemic began, but often we forget that patients were going through care in private hospitals and their care was also stopped, operations cancelled. So there's a great deal of harm that's come about due to this, and it's something we really need to look at. So thank you, David, and we'll hear from you later. Thank you. So I'd like to move on to our third speaker now, Professor Anthony Costello. Anthony is a paediatrician and he sits on the independent SAGE committee. Until March 2018, he was the director of the Department of Maternal, Child and Adolescent Health at the WHO in Geneva. He's a former director at the UCL Institute for Global Health and chair of the Lancet Countdown for Climate Action and Health. And in May 2016, he received the BMJ Lifetime Achievement Award. So delighted to have you here, Anthony, and over to you. Thank you. You might be on mute, Anthony.
Right, sorry.
Yeah, we've got you. Great,
No
thank you.
Thank you very much. It's really a pleasure to speak to everyone tonight. And I feel a bit of imposter because I'm a pediatrician, and most of my career I've worked on population health, primary care in other settings, and been involved in some service delivery and a lot of cluster randomized trials and the like. So in a sense, coming back to the UK a couple of years ago, I made assumptions about our health service that have been rudely awakened in a sense. And I'd like to describe that. So this is a virus that began in Chinese wet markets back in November, probably. It's almost certainly a bat virus or gone from bats through pangolins, unless you're a conspiracist, in which it's all 5G. But the first case was on December the 8th, and the Chinese were secretive. They didn't abide by international health regulations, but they did identify the virus quite quickly and sequence it before the end of December. But it wasn't until December the 31st they actually told WHO. And then, although news leaked out internationally, they didn't actually tell their own people about this. In fact, between January the 15th and 20th, they said there were no cases in Wuhan. And then when it all went into sort of mayhem on the 21st of January, they had to admit that they had a major crisis on their hands. And it was clear that there was human-to-human transmission, that this was rapidly spreading virus, that there were high or relatively high death rates, although people weren't quite sure what those would be. So WHO have very simple principles of control, and you've heard about all of this: finding cases, test, trace, contacts, isolate, support, and social distancing. But one thing that gets forgotten is that they always say, do everything at speed. Whatever you do, act fast. And on top of that, all the behavioral stuff that we've all got embedded in our minds from all the various messaging and the like. Now, we also knew that it was a bit like an acute respiratory virus from the first SARS epidemic or the Middle Eastern epidemic, the MERS virus back in 2015. And all the ITUs were prepared for a kind of acute respiratory distress syndrome. But actually, it's gradually made us realize that this is a different virus, and it's got all kinds of odd impacts. You have to manage the ventilation differently, and this whole problem of long COVID, which primary care physicians here are going to have to deal with over the next year or two, possibly longer. The slow recovery in many, many patients, the brain fog, which may be inflammation in the brain's white matter, and the heart damage. And there were frightening figures coming out about, 78% of people having it. And I was a bit skeptical until my wife, who'd set up a primary care COVID center 3 months ago, had an inferior myocardial infarction, completely out the blue. And the cardiologist thinks this is COVID related. And we know that this coronavirus will suppress the efforts of our lymph glands and spleen, and that it may well prevent patients from developing longer lasting immunity to it. And that may be another problem that we're going to face in the coming months. I just want to take you through 3 countries very quickly who all acted fast, but with different strategies. So South Korea, who had their fingers burnt by both the previous 2 epidemics, had a fantastic director of public health, infection and virology, he immediately developed a test, actually on the same day as the UK did, but then he ramped up the pharmaceutical production of reagents. And as soon as they got cases in late February, top right, you can see how they ramped up testing, but not more than 18,000 a day, so not massively, but that quickly brought under control the 2 provincial outbreaks. And without a national lockdown, they suppressed their epidemic. And although they're seeing outbreaks like everywhere now, they've had 9 deaths per million. If you go to China, after their secretive phase of almost 2 months, they did act fast. They moved 9,000 tracing and support workers into Wuhan within 2 weeks to cover 11 million. They locked down that hotspot. They treated cases, they isolated contacts, travel bans to other provinces, a risk-based prevention and control approach. They used big data and AI for the contact tracing. Every province had 24 hours of health education by TV, and they had a comprehensive financial support package, so no one felt out of pocket because of the need to isolate. And China currently has a death rate of 3 deaths per million. Now, Greece was different. Greece realized that it couldn't actually put in place a very aggressive test and trace system. So they monitored very closely as infections began to rise. They did a partial early lockdown before a single death, and then a total lockdown 2 weeks later. They only needed a lockdown for 6 weeks. Ours was 12, and they're currently at 51 deaths per million, although they are facing an uptick in infections right now, though not on the scale of the UK. So let's come to the UK and have a think about what's gone on that has led to our death rate of 650 deaths per million almost. The first striking thing was that there was no independent public health or primary care presence on SAGE, nor has there been one added. We do not have that presence on the scientific advisory group. The modelers followed a pandemic flu plan. They didn't model a lockdown or the test and trace process to think that that might be necessary. Primary care throughout the entire 9 months has been bypassed. When we set up contact tracing, unlike 9,000 for 11 million, we had 270 for 55 million from the existing Public Health England staff. No attempt was made to recruit volunteers from the 750,000 who volunteered, nor to recruit new ones locally. We didn't scale up testing quickly enough because we didn't prepare. We didn't use our NHS molecular virology labs, of which we have 44, until way later, almost in April. We outsourced test and trace, as we know. We delayed lockdown for between 2 and 3 weeks on what it should be. And frankly, we pursued and continue to pursue a kind of herd immunity policy, explicitly laid out by the Prime Minister, take it on the chin, but also by the Chief Scientific Advisor, Patrick Vallance, who went on television and radio to say that this was a good thing, that we all got this infection and only 1% of us would die, which would work out at about 400,000 people dead. So now look, I believe in primary care and population health. I think that's the most crucial part of any national health system. Primary care physicians, the most important workers. I'm rather shocked at the maldistribution of our national medical research funding, which all seems to go into the usual bioscience and drug treatment brigade. We need to spend far more on the social and primary determinants of ill health. But I want to do a thought experiment, and I don't know what you'll all think of this, but what might have happened if, from day one, as soon as we knew at the end of January, early February, that this was a real danger, it was spreading around the world, it had caused chaos in China initially, it headed to Iran, then Italy. So supposing we'd mobilized GPs and the local public health outbreak management teams, and we'd offered them sufficient funding for themselves as innovative, and in the GP case, private providers, to set up COVID secure testing sites linked to their existing courier systems, to send the samples to supported NHS molecular virology labs, get the results back within 24 hours, which is common, new staff to recruited to contact and follow up cases, monitor symptoms, discuss any deterioration with the GP so that people who were positive felt supported, and then support public health to employ enough contact tracers to work with GPs, link up with local volunteers and civil society organisations, and get the government to generously provide benefits to cases and contacts who are asked to isolate. Now, could we have done that? Now, I'm no expert on financing, so I did a back of the envelope thing. Supposing we gave £300,000 to an average GP practice of 8,400 people, that cost would be about just over 2 billion a year. Supposing we gave 10 million to each of the 151 top-tier authorities to strengthen public health in their catchment, that would cost just over 1.5 billion. And let's imagine we gave 30 million to each of the NHS 44 molecular virology labs to cover the cost of expanded testing. I don't know how realistic those figures are, but it comes to £5 billion. And I think, given the innovation of the primary care system, more than hospitals, that GPs, if they're given a target, given resources that they think will compensate them, and they are very busy people but have the staff to help them, I think this would have been a far better solution. And we can see this in the latest, the grey figure at the top is what local public health people are doing. As Polly said, 97% success in reaching and identifying contacts. The light blue and yellow are the ones being done by the call center contacts, which is only, it's above 50%, but that's pretty paltry. And with test and trace, the testing system through Deloitte's has steadily declined since actually early July, when we got down to the base level. And since then, it's now at 25%, which is hopeless, actually, if you're going to 25% of people who get their results within 24 hours. And the other thing is that nobody's isolating. Well, or rather, 18% of people are isolating, according to the latest survey, and this has not been monitored by government. This is done as part of a research study. So on all criteria, this system has failed miserably, and the result is, partly due to this, the savage rise in cases, which have shot up again today, I hear, to about 26,000. We are among the worst in Europe with France. We know that the percentage of people who test positive is rising across all regions, and the reason the South is not rising quite so fast is because they started off at a lower level, frankly, and that's the way pandemics work, but they will catch up over time. Most of it is in, or an awful lot of it is in young people, but they're not immune from long COVID. But all other age groups, with the exception, interestingly, of the 0 to 9s, are rising steadily. And we can see here the number of hospitalizations, again, increasing. And finally, on deaths, we're starting to see the uptick, which you always expect to be lagged. And we're, in the last 2 days, we've had approaching 200 deaths per day. So things don't look quite so good there. And we're in trouble because there's no sign the government is going to reform find, test, trace, isolate at all, despite the fact they had the opportunity when contracts expired in August, and they simply renewed them, ignoring the evidence and the appeals from public health. So what's going to happen next? Will there be a massive second surge? Will there be peaks and valleys, or a kind of slow burn? Well, the Academy of Medical Science report suggested 120,000 deaths by the middle of next year could happen. So that's double what we've had now. And the London School of Hygiene group said 350,000 deaths by the end of next year, which is a staggering and very chilling estimate. My view is slightly modified by Carl Friston at UCL, who's the top cited neuroscientist in the world, who is also a mathematician and a physicist, who uses a different kind of modeling called dynamic causal modeling based on Bayes, and I won't go into the details because I don't understand it fully. I'll just go on to what he suggests. His model is actually more complex than the epidemiological ones. He puts in estimates not just for the top circle, which are the standard epidemiological models, but also links it to location, symptoms, testing. And he says, look, it's not quite as simple because effectively quite a lot of the population are still shielding. Of those, about, well, up to half, or even probably a little less than half, would still be susceptible, whereas others may either have antibodies or natural immunity or possibly other forms like T-cell immunity, though we don't know that scale. And then there is over dispersion of transmission. In other words, a lot of people remain relatively non-infectious when infected. They don't transmit, whereas others are super spreaders. And in light of that, he comes up with a different forecast and says, look, the daily deaths will go up. It will depend upon all kinds of factors and how successful our find, test, trace, and isolate is, and loss of immunity, but it's probably going to peak out at around 200 per day. But he has had to adjust it, and one of the advantages of it is that he can enter the data from all parts of his model every week, actually, and see how it's adjusting, what's going to happen. But all models are uncertain and depend upon the assumptions made. Will we get a vaccine? Because that's what we're all waiting for. I hope so. I'm moderately optimistic that we'll get a partially effective one in the next 6 to 9 months. But we don't know how long immunity lasts. We don't know about safety and whether antibodies provoked by vaccines could actually make a second infection worse, as happens with dengue fever. We've never had a coronavirus vaccine developed. It can't be grown in eggs, so it's difficult to scale up. And it could easily take 2 years before we got large-scale availability. The other fact is indirect death estimates. For the developing world, we know that in the Ebola West African epidemic, many more people died as a result of the damage to health systems, unreliable infection control, disrupted community work. And this is an estimate based on that for the rise in maternal, newborn, and stillbirth deaths in 4 countries as a result of the COVID epidemic. But in this country, of course, we've got to balance with all the risks of a rising epidemic of COVID affecting cancer, survival, and heart disease, long-term conditions, and the like. Some of you may have read the lovely Guardian piece by Val Curtis, professor at the London School, who said, a lot of people are going to die of cancer this year, and I'm going to be one of them because she had metastatic cancer. Very sadly, she died yesterday, but she was a fantastic person who really did a great deal for sanitation in the developing world. Just to finish, we're in another problem right now. This was in my local park in London. People wandering around, actually. I knew one of these women. No lockdown, no vax, stop 5G, no masks, arrest Bill Gates. Well, that's all right. And defund WHO, which I think is a mistake. But and there is a simmering mood of resistance now. There's a lot of fake news around. And the final thing I'd like to say is that there are real threats to multilateral cooperation as a result of this. I think WHO has done actually pretty well on this pandemic, but is caught piggy in the middle as a scapegoat between the deterioration in China relationships, and that's having a serious knock-on effect for other areas of health that WHO is important for. So I'm going to stop there and mention 2 commissions that you can download for free. One on climate action and health, which comes out annually, and the next one is being released on December the 2nd, and the other earlier this year, chaired by Helen Clark, called A Future for Our Children, that thinks about the other massive crisis that we're facing, bigger than COVID, which is the environmental crisis. But I'll stop there.
Well, thanks very much, Anthony. That was absolutely fascinating and some very sobering thoughts, especially on the vaccine there. And it was incredible to see those figures around deaths per million in South Korea compared to us, and just huge numbers of difference there between the two. We're moving to the questions now. We've had one around that aspect with South Korea and us and comparisons. Are there some behavioural issues here around compliance with government messaging and how people react in different countries?
Yeah, I mean, a lot of stuff comes out saying, oh, they're Asian, they're different, they all obey, that's very authoritarian. Actually, South Korea is not that authoritarian, nor is Japan or Taiwan or Hong Kong. There's a lot of free-thinking individuals there. China might be a bit different. But, we as doctors know you cannot assume that when you give people a prescription, they'll take it. Just telling people what to do. I've done trials on this where you give them formal health education. It doesn't make any difference to their behavior. But the trials we've done where you mobilize communities and support, the kind of things that a lot of GPs do in this country with social prescribing, does bring about longer term change. And I think the idea that you can tell people to self-isolate and then completely ignore them is fanciful. And it's been shown to be fanciful. And none of the other successful countries did that. They would follow them up daily. They would have carrot and stick. They would, monitor what their illness was like and give them support and give them financial support and food and drugs and information and do it time and again. And we haven't done any of that. And it's really shocking to me. And the bypassing of primary care and local public health lies at the root of it. And David and Polly touched on the root causes of that.
Yeah. So David, Polly, do you want to come back to the main screen now and we can have a discussion? Great. And feel free to chip in, and all of you. So Polly, this might be directed to you, but as I say, do chip in, all of you. Polly, we've had a question coming in about the NHS and private outsourcing, and does Polly feel the public are aware of the extent of this? And ultimately, do they care about the difference between public and private delivery?
I think they don't care, perhaps, if there's an NHS logo on it, because it's so reassuring. And they see that and they think, oh, that's fine. Exactly who's providing it might not worry them too much. But I think if it were called Serco and Cytel, if it were called G4S, I think that would be a different matter. I think that would be in their face and they'd understand their NHS was in the hands of somebody else, somebody they don't trust, fundamentally don't trust those companies. The whole lot of them, Deloitte, KPMG, those are all names that are not warm and friendly ones with the public. Most of the public have heard of them and don't think much of them. So yeah, I think, again, as ever, transparency is the answer. If it had to be put up there up front, I think a lot of those people giving out those contracts and being responsible for that might think again. I suspect, I mean, I'd love to hear what the rest of you think, whether you think the public would rebel. I think they would.
David, have you any thoughts on that?
Yeah, I mean, I think it's a very interesting question about the extent to which we rely on the private sector within the NHS. The research that we've done looking at some local CCGs suggests that quite a number of them are spending between a quarter and a third of their total income in the private sector. And that's a significant reliance at local level on private providers. We've also seen quite a significant growth over the course of the last 10 years in the number of operations which are carried out in NHS-funded operations which are carried out in the private hospital sector. So that's increased to the point where now 1 in 3 NHS hip operations are carried out in the private hospital sector, and also 20% of cataract operations. Now you got then ask the question, well, so what? Why does that matter? Well, there are a number of things which perhaps aren't properly understood by the public when they are referred for treatment as an NHS patient in a private hospital. The first is, and this is something which has been documented in a number of instances where patients have died, that the post-operative arrangements for patients who are treated in private hospitals is substantially different to that which occurs in NHS hospitals. So private hospitals don't have any, very few private hospitals, sorry, have intensive care facilities, which means that if something goes wrong, the patient then gets transferred from the private hospital to the NHS hospital. The private hospital doesn't pay any cost for that, therefore doesn't have any incentive to avoid complications occurring. It knows that the NHS will pick up the pieces. The second dimension is, and it's very, very very poorly known, that post-operative care in a private hospital is handed over to the responsibility of a junior doctor, a resident medical officer. It's not left in the hands of an NHS consultant who has often left the hospital after the procedure has been carried out. And that arrangement, where the RMO is working 24/7, that's 168 hours a week, that's outside the European Working Time Directive. That specific arrangement is, one, avoidable. There's no good reason why those types of post-operative arrangements should be put in place. But two, has been found in a number of coroners' inquests to have led to the death of patients. Now, the third important dimension to this is that whereas the NHS remains responsible and accountable and liable for what happens within its hospitals, there is a very long history and very worrying trend within the private hospital sector to deny liability for the actions of consultants who are practicing in there, but also for other dimensions relating to patient safety. Now, if patients were aware of those particular risks, and we've done our best to try and make them aware of them, there may well then be a reconsideration about the idea of going into an NHS, as an NHS patient going into a private hospital. Our big concern with the new deal which has been announced is that the patient numbers are going to substantially increase in the private hospital sector. However, the private hospital sector is not equipped to deal with high-risk patients. So there is going to be some sort of trade-off that's going on about the extent to which the safety of patients is going to be considered as an issue in order to be able to get capacity to be able to meet some of the waiting time and patient list backlogs. Those are real concerns, they're major concerns, and they are not very well understood, and they remain, I think, a serious issue which policymakers really need to attend to.
Can I just ask you something? Can I just ask you, does that, do you think, outweigh the pleasure and the surprise? I'm being a bit devil's advocate here. Patients have when they suddenly find they're in a very luxurious private hospital. It's got, you know, carpets, private rooms, very different to being in a 6-bay ward with curtains between you. It works that way too, that people are quite pleased when they find they've got something very different to what the NHS provides, just in terms of, you know, the menu that they get for lunch.
I mean, I can't comment for how different people may approach that problem, but I can speak about the people who I know who have been either harmed in private hospitals as a result of some of the safety issues that I've talked about, or have lost loved ones. And I think they would quite resoundingly say that the idea of having a more pleasant environment, which may or may not be the case, does not outweigh having in place the same type of safety arrangements, the same type of multidisciplinary care, the same type of consultant-led care for post-operative arrangements, and also the availability of intensive care units. Because the other dimension, I think, when people talk about this is, well, it's okay, we can just, you know, have an effective arrangement between the private hospital and the NHS. Putting a sick patient in an ambulance is a patient safety risk in its own right. And so, yes, there is obviously the kind of the glossy brochures, and there's the nice menus, and there's the nice looking facilities. That's not the same thing as being a good hospital.
And we know that the regulation and oversight of private hospitals is far less rigorous than NHS hospitals, and it's not a level playing field either, where they cherry pick the easy, profitable operations. And as a GP, I know that patients can't be referred there if they've got a few other conditions, because they won't touch them and they have to go to the NHS. So it's not even, is it? So we're getting loads of questions in, which is great. But Anthony, I wanted to direct one to you, which is knowing that the UK did too little, too late, as you've said, are there measures the UK can take at this stage to try and rescue things?
Yeah, well, I think we're making things a lot worse right now, because the most obvious thing, which we in Independent Sage have been saying for the last 6 months, I mean, like a broken record, is reform, find, test, trace, and isolate, and put it back into where it's sustainable and long term and going to be more efficient. Look, I believe in a mixed market economy. I'm not rushing to nationalize airlines, for example, or people who manufacture spectacles or anything like that. I mean, we all accept that, but there are certain things that you gain a great deal from a proper state provision. My colleague Mariana Mazzucato wrote the book, The Entrepreneurial State, showing how much of what goes into the private sector and the innovations of, high tech, digital, all come from universities, which are funded by the state. And you could turn around and say, actually, most of the NHS is already private because GPs are private providers. But they have a long-term relationship with the state contracts. They believe in the state. They're highly innovative. They don't like to be overworked, but they made a lot of changes. I mean, they really responded to this pandemic with all kinds of changes that were not really reported. Everyone focused on the hospitals. So I think, and we get a fantastic deal out of it. I mean, I've had 2 superb GPs over the last 30 years, one of whom I think saved my wife's life in June, because he responded to symptoms, got her into hospital fast. I missed it, of course, which I'm still living to rue the day. But, we have a great service, and we're getting tremendous health statistics on actually a very low percentage. I mean, I think we spend just under 9% of our GDP. Germany and France spend about 11%, I think, and America, with its hugely costly, is spending about 18 or 19% or something. So, it's not the thing about if they've been successful. I remember Rupert Soames, the chairman of Serco, said, "This is our chance. We can now show how the private sector can really deliver." And it's been a total dog's breakfast from day one. Everyone knew it would be like that. We had an alternative scheme. Nobody put it into practice. I'm afraid a lot of the medical and health advisors, I think, have almost been complicit in this. They should have stood up and said much more about this. And ideologically, the government have deliberately bypassed public health and also the primary care system. So what can we do now? I'm really gloomy, because they're not reforming that. They've left a circuit breaker a month too late, because the scientists said, look, if you do it early, it'll have a big impact, and then you can reset it and reform, fine test. We haven't done that. Doing a circuit breaker now probably wouldn't have the same effect. It would require a longer lockdown. So we're going to slide into a horrible winter. I hope Carl Friston's right, that the death rates will be a bit lower. But actually, if Adam Kucharski and all the other people at Imperial are right, we could be heading for a disaster, actually. And I don't see a way out, because the government are not going to change.
Polly, as a journalist.
Can I ask you as going to ask me as a journalist, I'm asking you as a GP. Do you think that there's more? I mean, GPs are so respected and trusted. Do you think that there's more that GPs can do collectively? When you listen to Anthony's description of how that money could be spent, if GPs were given the funds, the power, the ability to run local systems, to keep in touch with people, to make sure that their advice to self-isolate is made possible and made easy, and that they are helped and checked on and all of that. I mean, couldn't GPs perhaps raise public awareness more of the disaster of this system and how they could do it better?
I mean, that's possible, and
David,
things had changed back in March.
David, you're a GP.
If things had changed back in March, Polly, then perhaps we could have changed things. But you know, GPs, like many doctors, are on their knees at the minute. They're overworked, and you know, we've been through a pandemic, and we've had very little time to actually take any time off, and we're just absolutely worn out. We've done surveys of the profession that shows, you know, that over a third of doctors are stressed and feeling depressed, and they can't cope. And I'm seeing it in colleagues, you know, we're really struggling now to deal with where we are. They're anxious, they're concerned about what's ahead of us. The government isn't providing the ability for us to do our jobs properly, and it is a real concern. The BMA is really trying hard to highlight all these issues, but
David,
it's really worrying, Paul.
David, you're in. How big's your practice? How many patients?
Big, 20,000 patients.
Okay, supposing we offered you £600,000 to your practice, 700,000 actually on my pro rata, to provide you with staff to enable you to sort out the testing nearby in a COVID secure place, get it couriered through your system, and have people to phone up all the cases and contact and liaise with public health, because that money could have been available to you. That way you would have been engaged, you would have had a consultant role simply to review each day the cases that have come in and just check that they're not deteriorating. It would have built it into your system, and the data wouldn't have gone missing like it does with everything. Would that have changed your mind a bit?
I mean, if we had a team of public health experts in each practice, provided with, you know, with support and backup, then it would make a huge difference. But you know, public health has been absolutely cut to the bone, and you know, so that they are unable to do that. But if that was available in every part of the country, it'd make a massive difference to do.
Why not? You know, if we had the money, we could have recruited contact tracers. We could have strengthened our public health. There are outbreak management teams in every district. We could have done this, but it required a mindset from the beginning with someone in charge who was going to mobilize the nation to do this and give them the money to do it, so GPs don't feel hard done by. Of course, they've worked their butts off. And I know, because my wife was running helping to run a primary care network. But I fully accept that GPs were very suspicious at the beginning because they thought they were going to be dumped with everything and not given any money. But if you ask them to do things and give them the right resources, I find that GPs are actually very innovative. They hit all their other targets.
And Polly, do you feel, you know, as a journalist yourself, what the role of the media here? How do you view your colleagues in print media and television? What responsibilities have they got? How are they dealing with it?
It's a category error, really, to look at journalism and responsibility. I don't ever speak for my mostly pretty repellent profession. Most of, 80% of the British press is owned by a handful of robber barons who don't live in this country or pay tax in this country, who have brought about Brexit and disaster on the heads of this country. Pretty much, if Murdoch hadn't been there, Murdoch had never arrived, I think we'd be a very different country now. So I don't ever speak on behalf of my irresponsible profession. I mean, there are lots of very good journalists, and some of them do work for those, particularly on the medical side, on the health side, actually. Some honest, straight journalists do work for some of those newspapers owned by those people. But by and large, those, newspapers that I regard as most responsible are fairly small circulation. I wish the Guardian were a mass market, but it's not. I wish the FT was a mass market, because I think its reporting is very good, but it's not. I think relying on the BBC is good. I think the BBC is very straight, and I think the attacks that it's under now are very frightening. And the idea that we're going to get foxified news, and that some new head of Ofcom is going to allow them to produce a kind of Fox News service, and they'll change the law about broadcasting, is very scary indeed, and I think a very real threat. It's the sort of thing that Cummings and Gove have been wanting to do for a long time. So journalism is in a perilous state, but I do think on the whole our health reporting is mostly not bad. I mean, I'd like to know what you three professionals think about that.
I think you're a bit hard on your profession, actually. I've got a huge amount of respect for a lot of journalists. Yeah, there are the scumbags and the paparazzi and all that. But actually, every year there are several hundred journalists lose their lives, particularly in developing countries, by trying to investigate things. And my experience is that most of them, okay, they'll twist your story and, you know, but I think well, most journalists try and do a good job. Not all, but I don't think it's quite as bad as you think, although I agree that the ownership by robber barons from abroad should be ended. I mean, that should be a priority for a future Labour government, I hope.
Well, Paul Dacre is more or less gone, that's true. Paul Dacre and MMR was a notable catastrophe, responsible for extremely bad things happening as a result of that. But no, I mean, I think perhaps experience of people in the health world of journalism is less bad than the experience of people in other worlds dealing with journalism. And it's, I think it's, you know, if it were balanced, if we had a fairly balanced press where there was, it wasn't in the hands of just, on the whole, the right wing, I might feel differently.
We've had a question now about New Zealand and why they've been so apparently successful. Is it that they've got more reliance on public health and how their system works? Does anyone have any thoughts on New Zealand?
Well, I mean, being an island and stuck in the middle of nowhere helps. And they introduced border controls, which was actually rather against the WHO advice, because the international health regulations rather argue against border controls because things can spread quickly and all the rest. But they did do that. And some public health people like Gabriel Scally says we were very slow to introduce proper border controls and probably allowed in quite a lot of people, particularly from the skiing areas of Italy and the like. But New Zealand also has a pretty good public health system and a very progressive government. And they've still got to face outbreaks, but there's, you know, as you've seen with the overwhelming victory for Jacinta Ardern and of course Helen Clark before that, you know, they have a kind of national solidarity that I think is missing in the UK and the US right now.
Good. And we've had a question about someone saying, do we have information on the big political showcase schemes such as Nightingale hospitals and McLaren designing and building ventilators? It seems the Nightingale units have not turned out to be as needed as they were, and why was this, and you know, was that a useful intervention by the private sector?
I mean, my view about Nightingales is that it was very good, it was done, and that we could show that we could do it. And perhaps we ought to be glad that it didn't turn out to be that necessary. It shows what can happen if people really put their shoulder to it. I don't think we should have wished that they were full. I hope they don't fill up this time. I mean, I'd be interested to hear what you have to say about that.
Well,
David, did you want to come in there?
Yeah, I mean, I think obviously one of the comments that was made originally was that China could build a hospital in no time. You know, why can't we? And then we did. What I find quite unnerving about the current approach to thinking about the future of the health service is that we haven't quite grasped the fact that the additional capacity that we have had to buy in from the private hospital sector and had to rely on the Nightingale hospitals is because of the fact that underinvestment in the capital of the NHS has denuded us of any spare capacity to be able to respond to a pandemic. And you know, I think one of the really important aspects of thinking about the NHS's response is, yes, we were able to ensure that capacity wasn't breached within the NHS, but one of the reasons why that happened was because we turned away so many patients from being treated. And that points to the fact that we haven't got in place sufficient capacity within the system already to be able to stand any type of shock. And there isn't to date any long-term plan for how much additional infrastructure we're going to need in the future, because let's not forget, this is not the first pandemic that has hit the UK in the 21st century. It is unlikely to be the last pandemic to hit the UK in the 21st century. And therefore, we need to be building into all of our thinking about the future of the health service and the future of the social care arrangements, the precautionary principle, where we start thinking about building in resilience and additional capacity. And we can't go about just renting facilities from the private hospital sector or turning conference centres into hospitals. We need to have a dedicated, funded, costed and planned system for our healthcare needs in the future. And that's, I think, the thing that's been missing from the discussion about Nightingale hospitals. Yes, we've been able to do it at very short notice, but that is a very ad hoc arrangement, and that's a very unsatisfactory situation for a highly developed modern society to be in. We need to have those plans in place for future capital infrastructure investment.
Oh, you're on mute, Anthony.
Yeah, that's better. Can you hear me?
Yeah.
Sorry, I was surprised they didn't use them to isolate people. I mean, in Taiwan and many countries, a lot of people can't isolate because they're in overcrowded conditions at home, and they need to be put in somewhere safer and can be monitored with mild to moderate symptoms. And in Taiwan, they requisitioned 7,000 hotel rooms for 24 million population. So the equivalent would have been 20,000 in this country. And we could have done that, and or we could have used Nightingale hospitals to put people who are mild or moderately sick or needed isolation away from abusive or overcrowded conditions. And we didn't do any of that. And again, that's where local control over these decisions would have been much more effective. And so I think isolation has been a massive failure, because you can do all the testing and tracing you like, but if no one isolates, it's pointless. Then you have to go to national lockdowns or circuit breakers, or tier 3, which I doubt is going to work.
So we've had another question actually, which is about a public inquiry, and when should that happen? What should it cover? And also, will it be used as evidence to push back against all the issues we've talked about tonight? Certainly the BMA has gathered lots of data and evidence over the last 6 months, and we would want to feed into that. But I wondered what your thoughts were on public inquiry, when and what should it cover?
Well, I hope there will be one. As I said in the beginning, my fear is that I don't see any interest, any reason why Number 10 should be interested in anything other than perhaps some very small technical matters being looked at. I can't see them wanting some great judge-led inquest into this, because the finger points straight back at them. There's nothing in it for them. And I'm not quite sure who else could initiate it. I mean, all sorts of, the Royal Colleges together and all sorts of people could possibly do it if the government won't. If you could get the might of the health institutions, possibly that could work if they find some good distinguished person to run it, who then maybe we could do that. But I think that they should be thinking about this already, because I don't think the government's going to do it.
And the other problem, it'll take 4 years, won't it? I mean, look at Grenfell. I live 2 miles from Grenfell, and we're now 3 years in, and they barely started looking at the actual people who I would have thought should have been criminally prosecuted by now about fiddling contracts and stuff, in cladding and all the rest of it. I mean, and you have some old judge that will go on for 7 years and write a vast report, and then it will be discussed for a day in Parliament, and people will cover it. And it doesn't really change. I mean, I'm sure we should have a public inquiry, but the idea that it will hold to account the current regime, I think, is naive. Yeah. We need quicker ways of doing that. Called election.
No, I think Anthony's last point about the need for accountability now is key, because I think what we're finding increasingly when MPs are asking questions in Parliament about what's going on, when the Public Accounts Committee asks questions of the government in order to explain what's going on, when journalists ask questions either through the normal routes or through freedom of information requests, there is often a very thick wall of silence. The Public Accounts Committee asked the Department of Health to provide it before the 1st of September, no later than the 1st of September, with all the details of all the money that had been spent in the private hospital sector. It has yet to do exactly what the Public Accounts Committee has said. And so I think the focus on a public inquiry would, obviously, we want to have a better understanding of why we've lost so many people. We want to have a better understanding of why so many parts of the economy have been ruined. We want to have a better understanding of how we've arrived at this particular juncture. But I think the more pressing point is ensuring that we get accountability now, that we get transparency now. And that is, I think, the challenge that journalists in particular face. And you have a number of MPs who, quite frankly, are pushing that agenda, but are being met by a government which doesn't really seem to care very much whether or not it gives back to Parliament the types of things that Parliament are entitled to and are requesting. So I doubt very much whether they'd be happy to sign up to the idea of a public inquiry, given that they're not even happy to sign up to the idea of passing back to Parliament the type of issues which it should be holding them to account for.
I do think select committees have worked quite well. I think Greg Clark chairing Science and Technology, and even Jeremy Hunt in the Health Committee, have really held a lot of people to account, and that's where you've got the answers, actually, for a lot of things that we wouldn't have known about.
Yes, there's nothing better than a vengeful, angry leading Tory to be in charge of health, who actually knows quite a bit about health. He is going to get his revenge big time, and maybe that's the committee that will really increasingly be landing punches where they're deserved.
Yeah. Well, listen, we're in the final.
With that, perhaps, is that a lot of the preparations that should have been put in place in relation to the pandemic were under the watch of the current chair of the Health Select Committee. So, yeah, there may be some slight conflicts of interest there.
We're in the final few minutes now. Just firstly, I want to thank all those who've been watching on. With the questions coming in, we're just too numerous to mention, but we've got through some of them, but obviously not all of them. So thank you to everyone for putting the questions in. Did any of you want to say a final 30 seconds on anything? Any thoughts for what's ahead of us, or any messages to those watching?
Just praise for all the NHS staff that have done a great job so far, every level. And, you know, unfortunately, they're going to have to, you know, do a lot more work in the coming months, I'm afraid.
Thanks, Anthony.
I'd like to say I'm very impressed that there are so many BMA members who are willing to take the time out, their precious time out, to join this webinar. And in the end, it is the medical profession, the nurses, the people who work in the NHS who are most trusted. And in the end, their voices do win out over politicians trying to cover things up and hide things. So I'm reasonably optimistic that all this stuff will out, and doctors will be, and nurses will be part of that process.
I would just second everything that Anthony and Polly have said there about the heroic efforts of everybody who's been working on the front line, the risks and the strain that has been imposed upon them. I think is an incredible response from so many aspects of the health service and so many aspects of the public sector. I remain in hope that the catastrophe that we are currently experiencing is one that we will learn from. I remain in hope that the failure of large aspects of reliance on large multinationals and contracted out services will cause us to rethink and to avoid making similar mistakes in the future. This is probably the turning point in terms of how we think about the role of the state in protecting the population from existential threats. And that is a very much needed lesson to be learned.
Well, I'd like to thank the three of you, Anthony, David and Polly. It's been a fascinating 90 minutes. And as I say, there was many more questions that we could have discussed, but it's been really interesting. And thank you for giving your time tonight. I'd just like to finish by thanking a few other people behind the scenes who've made this evening happen. And the main one is Frances Player at the BMA. She's been amazing, and we've planned this for a long time, and she's come up with the goods tonight and done so much work. So thank you, Frances. And I'd also like to thank John Ware at the BMA, and also Sabria, who's done all the tech work tonight and helped us get connected on this system. For all those of you watching and those who registered, there'll be a follow-up email which will have a video recording link in there, which will allow you to watch back. And there will be a small survey in there to let you feedback on what you've heard tonight. And thank you once again for everyone joining us, and I hope it's been helpful. The BMA wants to do its best for everyone, wants to represent doctors and try and keep the NHS on a firm footing. So thank you all for watching, and a very good night to you all.
Thank you.